Okay, well, good afternoon, everyone, and thanks for joining us. Most of you I know, but if for those of you that I don't, I'm Laura Dixon, and I'm with Spur Sports and Entertainment. I also currently serve as the president of the Texas Lyceum, and it's a few minutes after 4 o'clock on Wednesday, March 25th. And this forum is for the directors, alumni, and friends of our Texas Lyceum. And it's so that we can hear directly from our own health and public policy experts. So it's great to see that we have so many folks participating. Know that we have an hour scheduled, and we're going to start with Dr. Boom and then take it over, turn it over to Geronimo. And then after we get started, Judge Jenkins will join us. So this may be a little bit clunky, so bear with us. And as a reminder, please send your questions into our chat channel or send them directly to me via email. Also, for full disclosure, I think it's important to note that both organizations that Dr. Boom and Geronimo represent are Lyceum sponsors, and we greatly appreciate their sponsorship. Let's get to it. Dr. Boom, just going to turn it over to you at this point.
Okay, well, thank you very much, Laura, and welcome everybody. I think I'm the old timer of the group in terms of Texas Lyceum. Some of you may know Roberta Schwartz, who works for us as well, who was a president of the Lyceum a number of years back. And it's a pleasure to be here. So just to give you a little bit of my background, I run Houston Methodist, which is an 8-hospital system in Houston. And based in the Texas Medical Center, a 1,000-bed flagship academic hospital, and then 7 hospitals spread out through the community. I am an internist, so I started out 50-50 back even in the first days of the Lyceum. I was probably 50-50 clinical administrative, and then have moved on up, and I've been CEO for 8 years now, my 9th, but I still have about 100 patients that I see clinically. So I thought I would start actually with a little bit of clinical information, and we will be sending the slides out as well. So hopefully they'll be useful for you and tools that you can hopefully use in your personal life. And I'm not going to go in great length, but enough just that some handy tips. So these are the symptoms of COVID, of the disease. What you see here and what's very useful as physicians are trying to figure out, do you need testing, do you not need testing? And as you may be at home, worrying about some symptoms that you're feeling, is that in the vast majority, pretty much 90% of cases, fever is one of the symptoms. So if you don't have fever within those first few days, pretty good chance it's not COVID. It's not 100%, nothing ever is in medicine, but it is a very universal feature. The other completely universal feature is really cough. 2/3 of that's dry, where you don't bring anything up. About 1/3 of that is where you do bring up sputum, so it's a wet cough or a productive cough. And so those are the 2 biggest symptoms to really look for. If you do get shortness of breath, that's what we in medicine would say is kind of an alarm system. That's a symptom, rather, where you would want to be calling your physician and getting care pretty quickly. You can see the rest of the symptoms are significant, but not that high a percentage. And I'll show you a couple other details in a second that are useful. This is a curve of symptomatology, and basically the median is at 5 days, and you can see how steep the curve is, which basically says sort of plus or minus 2 days on either end of 5 days is really when most people are getting sick. Now, the tail goes all the way out, as we've all read, to 14, 15 days, which is why there's some longer term quarantine that happens. But most people, if you're sitting there saying, hey, I think I might have gotten exposed, that kind of 3 to 7 day window, 3 to 8 day window, something like that's going to be where most likely you would see symptoms if that was from a direct exposure. Of course, right now, this is widespread enough and becoming widespread enough, we're not always going to know if we were exposed. This table is kind of a really useful one to hang on to because it compares and really looks at the disease the way we clinicians would look, which is to say, okay, what else looks like this? Well, there's COVID, there's the common cold, and really by that I mean rhinovirus, which is the true common cold, but a number of other things that show up in what we call a respiratory pathogen panel, 4 of which, interestingly enough, are coronaviruses that are in the environment all the time. They're just quite different from this coronavirus, which is very unique, and they're pretty mild. They're like a regular cold. The flu, of course, many of us have had. We know we feel like we get hit by a truck. You're very sore, you're very achy, lots of fever, etc. And then, of course, it's allergy season right now, and so that can be really difficult. A couple of things I point out for people on this chart, but you can study it more yourself. But note runny nose and sneezing. Really, this disease is not causing that nasal kind of congestion, runny nose, sneezing, etc. So even though I know you go to the supermarket, and if you happen to sneeze right now during allergy season, everybody looks at you like you have the plague. You probably really don't have COVID. That's a pretty reassuring symptom in the scheme of things to have. And of course, fever, is a paramount symptom that you need to look at. I'm going to go very quickly through some of the characteristics of the virus because I know everybody here is so well read. This is a chart I've been using honestly since early January as this was evolving, or mid-January, because it really puts it in perspective of other illnesses. The range of that pink box has narrowed a little bit, certainly. Probably the transmission is between 2 and 3, for instance, not all the way up to 4 people. But that's higher than the seasonal flu, which is about 1.3, which means really the transmissibility of this is dramatically higher than with the flu, because the mathematics of infecting 2 or 2.5 or 3 people per person rather than 1.3, each iteration, it just gets faster and faster. And that's the logarithmic type of, or the exponential rather, type of expansion that we've talked about. I'm going to give you more detail on mortality, but the thing to point out here is, it's far lower than SARS, it's far lower than MERS. And the other thing on transmissibility, this is droplet transmissibility, which means if I cough and droplets go in the air, which is, respiratory material that has virus in it, that's settling out somewhere within a 6-foot diameter. That's why you hear the 6-foot social distancing. And then other people are touching that, touching their eyes, touching their nose, touching their mouth, those sorts of things, and infecting themselves. It is, with the exception of in medical aerosolized procedures, not a respiratory spread. Look at measles on that chart. That's what it looks like when it's true respiratory spread, which of course is very frightening. If I sit in a room with all of you and I have measles and you're not immunized, you'll probably get measles. Not the same situation, thankfully, with this. With all the mortality data you see, really what's being talked about right now is a case fatality rate. So a case fatality rate says of people who are symptomatic enough that we tested them, we realize they have the disease, how many are dying. Really, the thing that we would compare to those other illnesses is an infection fatality rate. We just don't know that. We will not know that probably till months and months from now, when mass epidemiological studies can be done, when they do some serology where they look at antibodies and who has antibodies and how many people were sick in a community. The good news about that is everything you see is overstating the mortality that actually happens for the people who get infected. What it's stating is the mortality of those who get infected and have enough symptoms that they're ending up in hospital emergency rooms, they're calling doctors, going to hospital emergency rooms, getting admitted to hospitals. And so it's probably overstating in almost all cases the actual mortality. And this is the early data, and as everybody knows, out of China, the mortality went up and goes up significantly with age. It also goes up significantly with other comorbidities. And this is an overall mortality being reported out of China of around 3.4%. More recent data, this just came out probably end of last week in Nature, so very high-level peer-reviewed journal. Don't spend too much time looking at the 3 colored dots. It's some statistical probability stuff around how much of the population is symptomatic or not symptomatic with the disease, which we don't fully understand. But it reinforces that key message, which is young people by and large are doing really, really well. And this goes up very significantly as people get older. In this study, it was a 1.4%. And I think most of us are really believing that the right number is probably somewhere in that range based on experience we're seeing in South Korea and some other places with large scale testing. Keep in mind the regular flu is 0.15% overall, which we'll talk about in a second. So it's still significantly more deadly than the flu, but it is not nearly as bad as some of the early numbers that we were seeing. And this is that seasonal flu versus COVID comparison. This still uses some of those higher level mortality data, but for purposes of comparison, you can see that overall mortality is in the 0.15-ish range or et cetera. But you can see the elderly population with the flu. It's why we pushed the flu shot. Is still pretty significant mortality. You can see it's far higher in COVID. I'll remember right now, you should still get your flu shot. It's still flu season. So if you haven't gotten your flu shot, get it. And every year from now, I think we've all learned our lesson. We need to be getting immunized. This is what's happening worldwide. Obviously, the flatter part of the curve now, in the perspective of now several 100,000 cases, it didn't look so flat when it was 80,000 cases. Now it's flattened out. And that was all of China. And really over the last month, you've seen it hit exponential spread across the world. And this is what has all of us so alarmed. This is the heat map for the US. You can see that obviously it's spread dramatically through the US. Thankfully, nowhere in Texas is a hotspot to the degree that we are seeing in New York, which is a massive hotspot, perhaps even the global sort of center of this right now. And of course, California and Seattle. Note, not too far from us, Louisiana, and particularly New Orleans has become quite a hotspot. And I can tell you, and I'm happy to answer some questions about that, we're seeing significant acceleration in the urban areas of Texas. This is, as of 2 days ago, what you see in new cases reported in the United States each day. Note that 2 days ago, we had over 10,000 new cases in the US. Remember, Wuhan saw 80-some thousand. So in 1 day, we're an eighth of that. We're going to far surpass that as a country pretty soon. There's some data here on the states. Thankfully, Texas, I think, is not quite top 10. One time I'm happy with Texas not to be number one. Keep it that way. But you can see New York, New Jersey, a real hotspot. And talking with hospital colleagues over there, it is pretty sobering to talk with them about what's going on. And really, if you see how it's contracted now, when you look at this chart, which we've been updating daily and getting from the link there from the New York Times, and my team updates my slides daily. Now it's 42,000 are unknown. Basically what that says is this is all community spread. It may be some travel within the US into one of your markets, but it's all community spread within the United States. Again, all of this is about flattening the curve. Our hospital infrastructure anywhere in the world cannot handle an exponential rise in cases that happens so rapidly. And so our goal is to keep the rise lower and out of the realm where it overwhelms hospitals. We saw that in Wuhan, where that was a problem. We've seen that in northern Italy, where it's a severe problem. And mortality rates are directly correlated with that rise, because once you start overwhelming capacity, you will have more mortality. These are two more slides here just showing the power of this. So we know it's 2 to 3 people infected. So if you use the average in just 30 days, if you have a 5-day span of infection, and since people are actually, as you saw, symptomatic at 5 days at the median, but they also may be infectious for 2 days prior. This is actually, I think, an underestimate of the power of what can happen here. And so 406 people infected if you do nothing. If you can have the transmission to 1.25, you can keep that down to 15. I mean, it's a marked difference. And if you can cut that even to 75% less exposure, it is even more dramatic, which is why we're all harping on this issue of social distancing, all the sacrifices people are making. This is real data in coronavirus of what an exponential rise looks like and the typical curve that you'll see. And if you were to look at Houston, you were to look at New York, you look at our country, and you'll see that on a slide upcoming. We, to varying degrees, are in that 18 to 20 something day realm. And even a day can make a dramatic difference in the curve if you can get social distancing in place. And this is a slide we've been updating every day, and I hate it every day I see it because it gets worse. This is the trend line by country of major countries dealing with this. Now keep in mind, this is raw numbers. So of course, US is way bigger than many of these countries, not way bigger than China though, of course. It is not a percent of population, which would also be a very interesting way to look at it. But note in the black line, the 43,000 number, how exponential the US curve is right now, right about day 21, 22, from when this really started accelerating. We are going faster and farther than China. And I think we should expect that's what's going to happen. Now, in China, that was all concentrated mostly in one place. So it was pure disaster in that one place. In the US right now, this is very spread out, albeit with some really terrible hotspots. And that's, that is a mitigating factor, but we have to get together as a country and flatten this out soon. And by soon, I mean now. Just to point out that all of us are using urgent care technology. It's really phenomenal. I mean, we had over 2,000 of our normal face-to-face patient visits with physicians yesterday were done virtually across many specialties, but urgent care is available from many providers. Really, the reason I put this here is to remind you that if you're sick, don't leave the house, pick up the phone, call your physician, call whatever your community lines are, use virtual urgent care so that we can have a controlled entry of you into the health system. So with that, I'll stop there and happy to take questions later, but I think we'll be moving on to my colleagues and then we'll be available for your questions. Thank you.
Thank you, Doctor. Geronimo?
Yes.
Turn it over to you now.
Well, I think that I'll start, but that was a really great information. I want to talk a little bit about the hospital operations and capacity in our hospitals. I think that's a question that people talk a lot about, and the role of public policy in that. I think for a lot of hospitals, we're all standing up our incident command centers. We know what our daily capacity is. We know what we're doing in terms of moving patients out to make sure that we address surges and trying to do our part to flatten the curve. I think at the federal level, starting, I guess it was a week or two ago, I can't remember the days now, the biggest issue at the federal level was trying to advocate for more collection kits and personal protection equipment. I think we're now seeing a little bit of movement around that in Texas, as we were told by some of our suppliers and others that we are the wave 2. And as was mentioned, New York is the hotspot, and they're sending a lot of material. I think one of the things to know is that your hospitals are prepared. They've been preparing for this since the last major disaster, and we can probably take a surge, but the idea here, especially from our collaborations with our local partners, is to make sure that individuals go to these drive-through testing places if they have them, and keep them away from the hospital. Make sure that we have the space to take care of the most sick. I wanted to just go through a couple of things real quick. At the federal level, I think there's a couple of things around public policy issues, not just the collection kits and the PPE, as you've seen the Department of Defense stand up an acquisition task force. You've seen other efforts to try to get us the kind of equipment that we need. We have enough right now, but as I think everybody has mentioned, if there is a surge, there'll be an issue with ventilators and personal protection equipment and masks and all the rest of it. But I think we're good for now, and I think there's a lot of people working on that. As you might have read, the third COVID funding bill has been negotiated. That's $2 trillion. I know we were advocating for about $100 billion for the hospitals. It's been rolled in with some other things, and we're reading through, trying to figure out exactly what kind of an impact that's going to have on the hospitals. As you may know, a lot of hospitals, the governor had put out a state order to stop all non-essential procedures. Our system, Ascension Texas, stopped the procedures Friday at 5 o'clock this past Friday. And I should mention that I serve as the Chief Advocacy Officer for Ascension Texas. We're about a $2.5 billion healthcare entity in Central Texas and in Waco. We do about $250 million in charity care a year. And part of our mission is to advocate for a compassionate and just society with our words and our actions. And we do that through a lot of our charity care that we do. I did mention the state. I want to just say that I really appreciate the governor's leadership, very steady leadership around thinking thoughtfully about the issues that hospitals need. And I really appreciate all of the lifting of regulations, whether it was around interstate licensure so that telemedicine could be stood up as much as possible, the lifting of restrictions around nurse certifications and making sure that we appropriately take some of those nursing students and put them where we need them. And obviously the telemedicine piece as well that was mentioned. I think the third one I want to mention is local efforts. As you all know, under emergency operations, the county judges and the mayors of the major cities are the leaders around emergency operations in every county. And there's just been a tremendous amount of collaboration with the hospitals around the public health department, standing up the drive-through testing, us moving some of our nurses to those drive-through testing centers. And then also the collaboration that's happening over the last couple of days with school districts. I know Commissioner Moran talked to the school districts about helping hospitals with daycare centers, and those are being stood up in our community around daycare for first responders, healthcare workers. And one of the things they're talking through right now too is how we might offer some educational opportunities for kids, not just in daycare, but they might be K through 12 in one of our schools right now. And then the last thing I just want to say is we are thinking through about what the new normal is going to be and transitioning out of this. And I think, as was mentioned before, we haven't reached the peak yet and we're trying to flatten the curve. But I think one of the things that we try to do in communication, I think for all of us as human beings, we want control, we want predictability, we want moderation. And that's one of the things that we try to, in this crisis, communication is over communicate the moderation of the information, the predictability of what we're doing, and then also the control piece, which I think has been mentioned before and can't be mentioned enough times, about our role, our responsibility, our obligation in what we're doing here. The social distancing works, the cleaning of surfaces, hand washing, all of that is really important to make sure that hopefully we don't see any of the numbers that we've seen in other places in our country and around the globe. And I think I'll stop there and open up for questions. Laura.
Okay, great. Thank you, guys. We have a lot of questions. They're really good. So one of the first questions is that around the testing. C19 testing has hardly been random. So with what confidence can we infer anything about infection and mortality rates?
Well, I think that I'll tackle that one first, if that's all right. So that is a very smart question, sophisticated question, and you're absolutely right. It has not been by any way random. If we roll back and when we digest this and dissect this as a country, one of the failures was not having the massive testing capability stood up early on, where the CDC would have been doing what it's supposed to do with surveillance and working across all markets to basically be looking for, is this creeping into the markets? And that didn't happen. What it would have been was literally doing testing every time, in certain markets with certain organizations or certain cross sections of markets, where they would have been looking and saying, every time you run a flu swab, we run one of these and we run it for COVID.
Mm-hmm.
Testing capacity has been a significant limitation. I'd say by and large, and I'll speak for Houston because I am in close contact with everybody in Houston, but I've also been in close contact with colleagues in both Austin and Dallas as well. So I think I can speak for most everybody in saying, the hospitals have all figured out in varying ways how to test who they need to test. I'll talk about us. Our team stood up the WHO test in January, so ran their first trial runs of it in January. We've been using our own test with a 12-hour turnaround, which is really extraordinarily helpful. It's interesting because of that, and we really are the fastest turnaround time among the hospital systems in Houston, just because others are using some outside labs. We have more known positives than they do, but we all are looking at our data, recognizing that we're all seeing a significant acceleration and surge in the data. I think in every one of the communities, hospital systems have worked together with public health officials, a variety of different strategies to stand up broader testing. All of the hospitals in Houston really each worked together. It was really a beautiful effort to support the city's effort to open up a testing site here. That's enhanced the testing, but there's still rate limiting factors in terms of testing supplies, personal protective equipment, and other things. FEMA has stepped in, done more. I think you're going to continue to see significant ramp up of testing over the next few weeks, which will give us better data. What I can tell you right now is I am 100% certain that whatever you're seeing reported right now, and I'll just talk about my community, is underreported at this time because the testing's not happening broadly enough. It's probably a pretty decent indicator of the people who are really sick with the virus because they're coming into the emergency rooms and getting care, but it's underestimating the number of people with the virus. And what I worry about that is we have some public officials and others sometimes who look at that and say, yeah, so it doesn't look like we have all that many. But the reality is the well person running around with barely any symptoms is ultimately infecting many other people, and some percentage of those people are needing hospital services. I've watched our hospital inpatient COVID census. So give you perspective, 8 hospitals, $5.5 billion system, 26,000 employees, 6,000 doctors, 2,300 beds across the city. While it's by no means taxing our institution yet, I'm watching the growth rate and I'm very concerned, which is why in our community, as other big communities across the state, we've worked very hard with the elected officials to put tighter restrictions in place. Some have called it shelter in place. We called it safe at home in Harris County, but we still have a couple of peripheral counties that have not moved yet with that. And I really think it is time for the urban counties to all be working in lockstep on this.
Yeah, I'd agree.
All right, thanks, Brian, for that great question. We have one similar, well, it kind of is touching on what you were talking about, Dr. Boom. Let me get back to that. Okay, this is from Catherine. She's interested in knowing about those who have been diagnosed but who have not died. As more folks are tested and don't die, won't the mortality rate decrease? And is there any way to collect data on those folks who are not symptomatic so as to really know the breadth of the disease?
Go ahead.
I think, yeah, the one thing I would say to that is I think that the DSH's, Department of State Health Services, has said that they're trying to create some kind of dashboard. I know locally we are as well. And I think only when you have that data of the individuals who have gotten COVID, the persons who are under investigation, will you be able to figure that out? I think it's still an ongoing issue or a new issue that we're trying to deal with. I don't know how Houston or Harris County is dealing with that.
Yeah, I completely agree. It's we're just not going to know the exact answer to that. I think we have emerging evidence, as I was talking about, of in my slides, really, of where some of those rates are. Those may still be an overestimate, which of course is great news. Clearly, and I am 100% certain of this because of the patients we're seeing, this is much, much more aggressive and much more deadly than the flu. There's absolutely no doubt about it. Whether that's 4 times, 5 times, 10 times, I'm not sure. It's not 30 times like it was looking early, but it is significantly more deadly and more challenging. We have a large growing number of people in-house, and they're pretty sick when we see patients who are getting admitted.
Okay, so will the heat have an impact on the spread of the virus? This question came from Robert Miller.
Sure, hope so. There's always been some theory that because all coronaviruses are seasonal, the traditional 4 that I was talking about, very seasonal, they have a capsule that's very sensitive to heat and temperature. Also, there's some reasons why respiratory viruses tend to spread more effectively in cold environments rather than warmer, more humid environments. So there's a whole bunch of reasons to hope, even now, that Texas has some advantages just geographically and climate-wise versus, let's say, a New York or a northern Italy at this time of year, or those kinds of things. What we don't know is whether true seasonality will happen and this will just diminish as a result of that. My instincts are no, and there's a couple reasons. One is, we're still very close to each other in air-conditioned environments and other things like that. It's not like we're living, in a non-air-conditioned world. That's one. But more importantly, we don't have any herd immunity to this. So when the flu pitters out, or coronavirus, typical seasonal coronavirus or rhinovirus pitter out, part of that is there's large herd immunity in place to those viruses as they come around. And we don't have that, obviously.
Got it. We had a question submitted via email. This was from Margot Stoglin. Should organizations be allowed to recruit and use volunteers at this time, even if they are designated as an essential function?
Go ahead, Geronimo.
Well, I think in our community, we're organizing ourselves in a couple different ways. One, I'll tell you, even our hospital right now is standing up a volunteer page to the public about what it is that we need, either volunteers who, here we're looking for people that sew so they can put elastic to our N95 masks so they last longer, as one example. I think that there's also the on the public side, the community side, there's also an effort to try to get physicians in the community to volunteer. I think there's a lot of different ways, and you have to look in your community about what it is that you need. But I think the most important thing is to follow the advice of the public health department in your particular area, because I know I think as even the governor mentioned, 200 counties didn't have coronavirus on Sunday. I think that number probably has gone up. I haven't checked it, but I know in talking to some of the county judges in our rural areas that their trigger is one case, and they're trying to figure out how to address these issues as well. So volunteering is helpful, but I think the right kind of volunteering at this time is really important.
Yeah, I would say, some creative things people can do, and a couple of things, a couple of thoughts right now. We have a lot of vulnerable people out there who are now socially isolated, sitting at home, barely having a relative come by for safety reasons. It's tough. We know that social isolation is actually a bad prognostic indicator for the elderly, for instance. So we're putting them in almost in harm's way to save, even worse harm's way. So things that can be done technologically, creatively to check in on those people, socialize with those people through your faith institutions, through clubs, through whatever. We're also standing up a lot of efforts, like Geronimo talked about, including digital volunteerism at our hospitals, right? So now you've got patients. We're not letting somebody be there as a visitor with them. And so we're giving digital visitation from volunteers, faith leaders, and others like that. So there's lots of ways people can get involved for sure.
Mm-hmm.
We have a question from Zach Dana. I'm told Texas is short 9 million N95 masks. What are our realistic near-term options?
The supply chain is a fluid number. I think that depends on each of the hospitals. I think we have been trying to conserve as much supplies as we can. And I think we're getting some supplies in now, but obviously, I think for us, if you think about New York City and think of it as like wave one or the crisis, they are in a crisis situation. I think we, with the shelter in place, especially in a lot of our major counties, we are more in trying to manage and waiting for that curve to go past not having more cases. And so to that extent, I think every single day we are getting dental offices, the Texas Oil and Gas Association and others donating equipment through various ways. And our supply chain is checking all of that to make sure that it's medically graded so that it's available in our hospitals. And so I think that there's a lot of different things that are going on. I have not heard that number. I think that number might be the requests that a lot of the hospitals have. And I think it depends again on the supply chain. And again, the governor has stood up a task force around supply chain. Then the federal government has as well. And we've even had some manufacturers who have offered to create face masks and other equipment for us. And we're talking to them, working through all of those requests right now.
Yeah, I could say ditto on all of that. We feel pretty good where we are today. It's really an issue of where are we in 3, 4, 5 weeks, particularly as if we see any massive surge. And that's why you see so much time and attention to this, so much effort. I feel pretty good also about what I've got coming in. And I know my colleagues around the Texas Medical Center would say the same thing if it comes in. And you got it ordered, you think it's on a plane coming from China, and then sometimes you find out that, you thought you had something coming and it just went somewhere else or it vanished somewhere. So it's very frustrating. The other issue, quite frankly, is there's a lot of price gouging right now. I mean, these things that we were buying for $1.25, we're lucky if we buy them for $6.50 now. Surgical masks, which were 7 cents, they're 84, 85, 90 cents a piece. And you're talking buying hundreds of thousands, if not even millions of these things. So we're also starting to talk about how we can get some help with some of that. There was an auction site in Houston that auctioned to the general public, and the AG is stepping in to deal with some of those things. But we've got an issue just with price gouging in general. We don't have a problem with there being a higher rate and people making a profit as an incentive to get new production online and everything else, but not at the rate of 5, 6, 7, 8, 9, 10 times the regular price. It's going to pressure really everybody, and we're all in it, competing for the same goods. And so it's just kind of a crazy situation.
Mm-hmm.
Dr. Boom, you touched on immunity early in your presentation. We've had a couple of questions related to that. One, if you've had it, can you catch it again? Can you discuss the likelihood of secondary or tertiary infection cycles? If social distancing measures are relaxed prior to vaccination or immunization?
Sure. So first answer is we don't 100% know, but there's every reason to believe that people will have immunity after they have this. In fact, one of the very unique things that institutions like ours are working on in terms of a therapy is it's called convalescent serum. This goes back 100 years. You take somebody who's recovered from a disease, you basically plasmapherese and get out their plasma, and then you give that to someone else because it's got a bunch of antibodies in it that can then help that other person. And there's some promising data out of China on that, and academic institutions here in the medical center are all working together to do large scale of that at some point. So yes, you should be immune if you've had it. There's always going to be exceptions, of course. There's not any indication to date that there have been mutations in the virus that would somehow change that either. So there's no indication to say it's mutated and now somebody's going to get a different strand of this. In the back of our minds, all of us are worried, could this become a new seasonal virus similar to the other coronaviruses, similar to the flu, where it mutates every year and we have to follow that now. The good news is once we have a vaccine, they usually can keep up with that and vaccinate on cycles. The other question is a very difficult one to answer. I'll tell you my personal beliefs and I think what's emerging with a lot of people. You know, clearly when we're watching China with great interest, when you release the restrictions, if everybody just instantly goes back to the way it was, unless the virus has completely vanished, which it won't have, you have significant risk of another curve, another issue, shutting down again, all the different things. So I do believe what's going to need to happen. I think what we're doing now in my sort of terminology is we're trying to get the lid on this. We're trying to get this under control, kind of bring it back to where it was in January when it started showing up in Singapore, and then act like Singapore as a country. So what does that mean? That means we're still going to have significant restrictions in place, not that shuts down communities kind of like we're doing now, but in terms of all the best practices around hand hygiene, social distancing, telecommuting. A lot of things are going to be different for quite a while, I think, most likely in doing that. If you look at what Singapore does, they measure temperatures just about everywhere you go. If you have a temperature, you're not going into that mall. You're going home. You're getting followed by public health. We're going to have to do things along those lines. We're going to have massive screening capability so that we're able to follow and hotspot and quarantine where that happens. And we're going to have to really dramatically increase our public health infrastructure in order to do that, because you have to really do that. And that's really, if you look at what a Singapore or a South Korea have done, I think we're going to have to do that. We just have to get the genie back in the bottle before we can go do that. And when we are able to do that, then that's got to be the technique. And I think it'll be a sort of a slow release of restrictions as we slowly go back to work. And I don't know when that is, but it's not anytime in the very near future.
We had a question about the flu shot and your earlier encouragement to go and get it if you don't already. This question's from Jane, and she's in Houston. Her comment is, in Houston, most pharmacies are out of the flu shot and are saying they won't get any more until August for the next flu season. And people right now can't get regular doctor appointments. Do you know how anyone could get the flu shot right now?
Well, that's a limitation, and I'm sorry, it's a reality, right? So in a normal flu season, most people, even though they could still be getting vaccinated for a while, don't. And so and frankly, the pharmacies and supermarkets are the primary fundamental site. Yes, doctors' offices do this, but they're the fundamental site. I don't have great advice other than keep calling. If you can't get it, you can't get it. We're at the tail end of the season, obviously. To me, the more important message is only 45% of adults in the US population get the flu shot right now. It's why we have tens of thousands of deaths from the flu each year. We just don't see it in the way we're seeing it with COVID here. It's not breathlessly tracked every day, and it's not, rapidly spreading on an average year like it does normally. But we have people in our hospitals every year whose lives could have been saved if other people around them had gotten a flu shot. So I do hope this changes some of the behavior around that, and all of us should be getting the flu shots, and all of us should be getting the other vaccines. It's the irony is, in the middle of all the craziness of anti-vaccination garbage, I'm just going to put it out there, here we are with COVID, and I promise you half those anti-vaxxers are going to be lining up first to go get their shots, because we're going to all need to do that to get this stopped in its tracks eventually. So
thanks. This question's from Dustin. In addition to the health benefits of sheltering in place, there are substantial economic consequences to many industries and businesses. At some point, the economic consequences of poverty-induced health issues, starvation, et cetera, will potentially be more substantial than the health consequences of the virus. How should elected officials be weighing these factors in the coming weeks as the economic issues become more pronounced?
You want to take that, Geronimo, and then I'll.
Yeah, I can. Yeah, I can talk about it from just an educational perspective. I also happen to also serve as the president of the school board here in Austin Independent School District, and our payroll is about $15 million a month. So if we close schools, which we haven't decided, and this is not a public statement that we will be, but if we end up closing schools, that's $150 million impact. And I'm sure businesses are doing the same kind of analysis. I know our healthcare system, as well, as I was mentioning, I think 80%, if not more, of our revenue is gone because we stopped all the procedures, the non-essential procedures. So I think there's going to be a really big challenge in how we transition back, whatever that new normal is. And it's going to be a challenge, I think, for some school districts. And I'll just give you an example of ours. We have about 30% reserves. So we think we can take the hit for it, even if we don't have any federal or state funding coming. But we'll see. I think with hospitals, you're probably going to see a fourth COVID bill at the federal level, where some of the issues will need to be addressed. But obviously, public health and public safety is the first thing. But we are totally feeling the tension between the need to keep our economy going and the need to keep our community safe. And I think local leaders are making decisions about whether or not we save people's lives. And I think for us, the more we can do to save people's lives, it's worth it, but it's going to have an impact. It will definitely have an impact.
Yeah, so let me chime in also. So in Houston, the UT School of Public Health has a model, and this is actually what really was the catalyst to get, over the last couple of days, to really get the further restrictions in place. And the model basically said, I'm going to try and keep it simple. It's a very sophisticated model, but basically act now and we'll have 3,400 COVID infections in Houston. I think actually the genie's out of the bottle on that one. It's going to be higher than that, but still directionally correct. Act in a week and it's 24,000, and act in 2 weeks and it's 153,000. That's what the model showed. And so, I am the first to understand, the economic issues. And I mean, as hospital systems, we all see all of what we call social determinants of health and all the things that interplay for people's health. And we don't want people harmed by this. Of course, none of us want to implode the economy. As Geronimo said, I mean, hospitals are getting beaten financially because basically, my models basically show as much as a 50% decrease in our revenue while expenses go up for several months. I mean, it's brutal. Yeah. But we're doing what we need to do, and we're doing the right thing, of course. So what I'm saying to people is, if we do that 150,000 and we have that kind of impact over a couple of weeks, and remember, that's waiting 2 weeks to do the same things. That's not never doing those things. The economic impact is dramatically worse than if we rip the Band-Aid off now, take these actions, get things back in control over some course of time. And none of us know exactly when that is. Data will tell us. It depends how far things have spread. But, in the order of some weeks. So that same model said, and I'll go with the middle model. The middle model said it peaked by April 15th versus, April 7th. That's a very, that's not dramatically different time, but it's not that far away if we can get to a peak like that, even at that higher number. The big one, you're not out of the woods until end of June. And, that's still doing all the things we said in 2 weeks. It's not saying do nothing. And so we have to. I mean, we absolutely have to. It's why we've been pushing these county judges, obviously, in Dallas County, really the first big county to go. And I applaud the judge there for doing that, and others fast followed. I understand where the governor's very thoughtfully been saying, I'm not so sure about all these counties that have zero. I personally would strongly urge that, and if I were one of those county judges, I'd either move before that, or certainly watching what's in counties adjoining, or I'd have a trigger of 1. And if I have 1, it's done. I do it so that I can get this controlled. because otherwise they're going to get out of control. And where I fear for the rural markets, I mean, in Houston, it's hard enough, but we've got lots of hospital capacity, lots of different hospitals, same thing in Austin, Dallas, San Antonio, et cetera. But if you go to small town Texas, you're a long way away from hospitals. We already have rural hospitals that are in very bad shape. Many of them have, not many days cash on hand. They're not that liquid. They could get stretched and stressed very quickly. And so that's another thing for those judges to take into account.
Absolutely.
Bob, I hope that answers your question. There was a question about the seasonality of COVID-19, and if it is thought to be a seasonal virus, why are we also seeing Australia start to experience an exponential growth rate?
So that's back to what I was saying before. I think this is such an explosive virus that even if it does have some temperature variation or sensitivity, I think it's overwhelming and goes from person to person much more quickly than that. And I think, to me, that's probably the main factor. There's some data emerging the last few days that suggests, though, that we do have some more temperate regions that are experiencing slower spread. I think what's unknown right now is that just timing and just statistically where it bounced around and where it went to, or is that true effect of what we're seeing in temperature differences? Certainly, New York City was really a tinderbox for this, right? Very close proximity, lots and lots of travel, lots of people sharing small spaces, and frankly, still cold temperatures where we do know viruses will tend to spread more easily.
Okay. Next question this is from JR Trevino. Do you have an indicator, have any indicator of what percentage of people that have COVID-19 are asymptomatic? No
one knows. I don't think I've not seen a study out there that has a good estimate on that. I don't know if you have, Geronimo. It's significant, though, I think. Now, is that 15, 20, 25%? I'm not sure, but particularly in younger people, there's probably a pretty high percentage. Either asymptomatic or so mildly symptomatic that somebody just feels a little run down. They don't think anything of it, that kind of thing.
Okay. And this question is from Jeb. Is contact tracing taking place with regard to testing, meaning proactively testing everyone who may have been in contact with a positive test patient if they have no symptoms?
That's going to depend by your public health department, by their access to testing. In theory, yes. In practice, I'm going to say probably not, given some of the restricted availability of testing. Right now, honestly, in these bigger markets in Texas, we're past that. It needs to happen, but we need to get the social distancing and all the other things to get it back down in a level of control. And that goes back to my remarks earlier about what would need to happen after that.
Yeah, I would just add there that when they're tracing, we're limiting right now. I think if you have symptoms, if they trace you and you have symptoms, then they might send you to go have testing. And testing, as I mentioned, on the public health side, what they're doing is prioritizing first responders, 65 and over. And I think those that are that have symptoms, they will go and try to test them. But I think you're exactly right, Dr. Boone. I'm not sure we're testing every single person. Although I will say one thing, the innovation and creativity that's going on is tremendous, and it's happening every single day. In fact, 2 days ago, we reported that we were working with a lab to do a test inpatient that could be done within 45 minutes. Not to the public, but to the inpatient, because obviously that's where the more serious cases are going to be. And I think you're seeing a lot of that creativity and innovation as we continue to try to address this public health issue.
Yeah, and you're going to see different testing techniques. So right now, everything is PCR, which is basically you amplify up some genetic material so you can test it. It's a swab, either nasopharyngeal, oropharyngeal, so back of the nose, back of the throat, or you're testing sputum. But the next thing you'll be testing either for antigen directly like you do for the flu with rapid flu tests. That may also be something that would be rapid fire. Also blood tests, certainly at least looking for some of the antibody serologies that happen. It may not be a day one kind of test, but it may be useful thereafter. And of course, those types of tests are very scalable, and that's one of the advantages.
Hmm.
Okay. This question comes from Kathy. She's saying her son has COVID-19 and his only symptom was the loss of his sense of smell and taste.
Hmm.
It is a symptom around the world, but doesn't make the lists here. Can you
Yeah,
comment?
it wasn't on that slide because that slide's from probably 2 weeks ago, but there's emerging data to say it's a very quirky, unusual, not well understood symptom. And there's a population of people that are getting a loss of smell, no question. My wife, who's a pediatrician, was actually sharing an article with me on that just last night. So yes, that is a very real phenomenon. You'll start seeing it on some of these lists for sure.
Yeah, and the New York Times had a really good article on that.
Okay, we, just a heads up, we are working on getting Judge Jenkins into the call right now. I'm gonna tee up one question while we're plugging him in. This is from Walt Massey. What is your bed strategy? Are there lessons learned from Italy or South Korea that guide your thinking? Are you worried about the ability to bring a surge capacity online before the anticipated peak need in Texas?
I'll take a crack and then Geronimo, you
Yeah.
next. Yeah, I mean, that honestly, the reason we are out there, I mean, we collectively, the medical community, beating the drum so loudly is because we've seen what's happened to those places and we know the horror stories that creates, and none of us want to be there. So again, that flattening the curve we talked about, every one of us is working on surge capacity. What I like to call it is surge in place. Really, many of our strategies are surge in place. So eliminating elective surgeries was one major activity we all did that basically uses less equipment, uses less personnel, fills up fewer beds, opens up beds for later. We created capacity in a hospital that we have where we weren't using some units, and now we'll have an additional 42 beds there. We ended up with a building we'd done in our main hospital, taking our MICU and turning it into nothing but COVID. And then moving people into some areas that had been shuttered that we reopened. We've got a ICU online coming online in one of our other facilities. And then really the next step is, if you have to keep surging in place, you look at all the places where you normally take care of very high level patients. So operating rooms, the PACUs, which are, you know, the pre and post surgical areas, and many other areas like that you can actually take care of critically ill patients. You can bring into use a lot of the anesthesia machines and other things like that and convert them essentially into ventilator capacity, et cetera, et cetera. So there's a whole dramatic surge that can happen internally within the hospitals. The first is just opening up capacity, and then all these other things. And then frankly, after that, it starts becoming, you know, do you need a Navy hospital ship, you know, coming up the Port of Houston, or do you need to set up field hospitals, et cetera, like we do sometimes post hurricanes and other natural disasters. So all of that is in planning.
Yeah, I would agree. I mean, I think that the governor lifting a lot of regulations was really helpful. I think they're expediting. For example, I just literally a couple of like an hour ago, we got approval for some additional ICU beds in our pediatric hospital because they were planning to inspect them in the end of April. Well, they expedited that for us now. And obviously all the planning that goes on with bed capacity and allowing us to put 2 people in one room. There's just a lot of different strategies that are going on. And also the bed capacity, just remember, bed capacity is a daily issue that's being dealt with because there are patients that are coming in and being placed in different places. I think the most creative or novel idea I've heard so far is there is a long-term facility task force in our community that's looking at emptying out a nursing home in case we need capacity of nursing home individuals that have COVID and putting them in there. And there's other kind of efforts along those lines as well, and making sure that we have the bed capacity that we need to. It's an important issue, and I think there are a lot of people working really hard every day and every night trying to figure it out.
When you say emptying out the nursing home, do you mean rehousing?
Yes,
Okay.
yes, I should say that. Transitioning them clinically appropriately to other facilities so that you don't have, for example, a lesson learned from Washington, where you left the patient there and then it just started spreading in that particular facility. And again, these are creative ideas that are being talked about, being planned, just in case there's an issue, but there's not one right now.
Yeah, we're also working on some sites. So sometimes, you have a patient, let's say, who has COVID, they have nowhere to go. They're homeless. They don't have a home environment. There's at-risk people at home. So we're looking at solutions for where those individuals could get housed, working with the county, the city, looking at patients who may be on the tail end of a clinical course, and we need to save the most acute hospital beds for the really sick, but they're sick enough they still need some care. So can you put them in some other community facility where you staff them at low levels with nursing, but where you're able to care for the last needs they have before they can go home? So lots of creative strategies ongoing, all collaborating across the community and collaborating really across different communities as well.
Okay. Judge Jenkins, are you on the line? Okay, we're working through this, guys. It's almost 5 o'clock. I'm going to pose one last question, and then if you guys could leave us with some go-to resources, like what websites would you refer people to? Because we have a lot of questions that we didn't get to for the best information, so that we can include those in our follow-up from this call. We would greatly appreciate that. The last question is from our chairman, Sanjay. Looking further down the road, if vaccine development and testing takes 12 to 18 months, should we be planning for a repeat in 2021? What could we do between now and January 2021 to get ready?
Well, that's a tough question. We don't know the answer. First off, we don't know. I mean, there's a couple scenarios, right? One is if this is seasonal and this pitters out for seasonality. If we look back to 1918, 1919 Spanish flu, granted a different era, of course, from a hospital perspective, but from an infectious disease, it doesn't really care whether it's 1919 or 2019 or 2020. What we saw was it came back after the summer with a vengeance. And so if this pitters out for seasonality, we should plan that it's coming back, and we should do all the things and be ready to treat it like they did in Singapore. Frankly, that would be fabulous news, obviously. I don't want it to come back, but if it goes away for seasonality, it's great news because it gives us several months to basically say, okay, now we know what we as a country have to do to be ready and act just like Singapore. And we can actually predict based on temperature and when these diseases come out, when it'll be back. And of course, you're racing towards a vaccine. So that's one scenario. I think the more likely scenario is this just continues and we get a lid on it at some point. That really depends on how well we all work together. When we get a lid on it, I think we're going to have a, whatever that is, 8, 10, 12 month, 14 month period where we're doing those kinds of Singapore activities where things are not normal, where we're racing towards getting a vaccine in place to get the herd immunity that we need at that point in time. That seems to me to be a potentially plausible scenario as well. We're watching China pretty closely to see what it looks like as they ease the restrictions.
I agree with the doctor. I think there's a couple things. I remember being on an advisory board for Texas A&M when they were applying for $1 billion contract from the federal government around creating vaccines for pandemics. And back then they were saying that it was going to take 6 months to get to a test and about 12 months to get to a vaccine. And I think I was just talking to the head of that yesterday, just because they were my former boss. And the fact that we now have testing weeks after it's come out, I think to me is a really hopeful sign that innovation, creativity, all of us working together can get there sooner. I think just as the doctor said, we don't know when we're going to get a vaccine, but the fact that there are these facilities like the one at Texas A&M with those labs and other places around the country that are racing really fast to try to get there makes me hopeful. But it also makes sure that we highlight what we're doing, the social distancing, the cleaning of surfaces, washing hands. You've heard it so many different times, but that is the power that we have to try to slow this down until we get to the vaccine. And it's sort of a race. If I had a graph, I'd be, here's the COVID going up, here's the vaccine trying to get there, and here's the test. And so there's you can put it all in one graph and see how we're all trying to do our part to make sure that those numbers, the fatality numbers, really don't go as high as some of these models say they will.
All right. Thank you. What resources would you direct us to for a lot of these follow-up questions that we didn't get to? Where are the best sources for information online or in our communities?
So I'd point you to coronavirus.gov. That basically gets you to all the CDC coronavirus information. It's actually very in-depth. There's a lot of really good information there. That is one very good source of information. I'd direct you to different hospital systems, and you can pick and choose. All of us have stood up a lot of information that's useful on our website. Certainly feel free to use Houston Methodist. I'm sure Ascension would say the same thing. Other great institutions around, and then, frankly, stick with credible news sources. One of the things I've been doing is playing whack-a-mole on a lot of things with, very well-intentioned, very smart people who sometimes are sort of getting, something sounds too good to be true, and in this time of everything else, are sort of biting the line and starting to get reeled in, and we're having to sit there and say, that's actually pseudoscience. That's actually not correct out there. So, I'd stick with those kinds of reputable sources. I don't know, Geronimo, if you have any others to add.
I think that the local county public health department websites have been really helpful to the local community to explain how we're in the various stages. And I think, as the doctor mentioned, we're in community spread now. When we were trying to contain it, where we knew where that person had gotten COVID and who they were tracing back to. And as you mentioned, we're way past that, but your public health departments, especially those that I know of in the urban areas, are really good. And the CDC website, absolutely the place to go to and find that data. And there's a lot of danger. That whack-a-mole, I really appreciate the way you said that, Dr. Boone, because even the issue, one of the stories I just read was about the fish food, I can't pronounce the aqua stuff for the malaria. Yeah, and so that folks can get misinformation and act on it. And I think we're trying to tell people what we know, what we don't know, and what we think is going to happen. And so I think, again, for us in healthcare, we're trying to share what we know and that people can have control over, the predictability, the moderation. That's what we as human beings need to make sure that we're not increasing stress within our own families and in our community and across our state.
Totally agree.
Yeah, thank you. Well, thank you, Dr. Boone. Thank you, Geronimo, for your leadership and your time here today. And thank you, Lyceumites and friends who joined us, just for your attention and very, very great engagement. May you all and your families stay healthy and safe and connected so you can continue to guide our state through this complex time. Take care, everyone. We will follow up.
If you're still there, this is Judge.
Oh, look,
Jenkins.
Judge joined us. There he is.
Hey,
Well,
Judge.
I've been with you, but you've had me muted. So
Yeah, sorry about that.
but it's good to be with you. I don't know if the camera works or not. Looks like it doesn't. I just want to say this. I've heard, and it sounds like you're all on the right track. I think I can turn the camera on. Let's say. Yeah.
Oh, there you go.
There you are.
All right. Hello, everyone. I'm here in the EOC in Dallas. I want to take some time to talk to my Lyceum brothers and sisters. And a lot of you may have left the call. For those who did, I'm sorry I couldn't be on earlier. We've had several things pop today. For those of you in other parts of the state, I want you to understand that yesterday we had 14 positive cases, and that was down from the 21 that we had the day before. And I had people on social media saying, it's getting better, you're overreacting. And I wish that were true. Today we had 77 positive cases and our 6th death. This is an unprecedented time, and it brings me no joy to put forth orders that will lead people to what may be irreparable financial harm. And it may ruin small businesses. I pray not. And I think if we work together, we can come out of this intact on the other side economically. But it may end up where small businesses, if the people put their whole life into opening that small business, they don't survive as a business. But we've got to look at the public health, and we've got to put life even over our livelihoods, as hard as that is. Okay, and there are no easy decisions left to be made, and the ones that we are making today are harder than the ones we made yesterday, and the ones we make tomorrow will be harder still. But you're all leaders, and we've got Republicans, Democrats, at least a few people that claim to be independents in the last year. But you're all leaders, and we all can put our politics aside and focus on the public health. We need to convince all of our leaders, Governor Abbott, but also our county leaders to move to shelter in place. I'll give you just a couple of facts on this from Dallas County. Anybody can go to COVID Act Now, either .com or .org, which was prepared by doctors in England, I think primarily. And I've had some people say, well, that's just too dark of a picture. That's too pessimistic of a projection. Let me say, the way medicine works, and we've got a doctor here with us, we look at peer-reviewed journals, articles that are published in journals 2 years after something happens. We do exhaustive studies on new drugs that take years. Look, these are sophisticated, wild-ass guesses, all of them, okay? We're dealing with the scientists are doing the very best that they can with a fast-evolving, novel, new virus, and getting the information that they have that's coming in daily and trying to make their best guesses. I'll give you an example just from Dallas County, which has a stronger healthcare system than most other places. Okay, I'm not saying it's the strongest, but it's certainly stronger than most of the 254 counties. If we have a 2% prevalence rate of the coronavirus in Dallas County, then we have enough beds and ventilators for people. If that gets to 3%, we don't. If it gets to 5%, we're 5,000 beds short. If it gets to 40%, which by the way is about half of where that COVID Act Now number is that the scientists have put on their website, we get to about half that, we're 70,000 beds short. Okay, so this is an unprecedented time where we need to act. We need to get our leaders to act, but we're all leaders and we need to act. And I need you to exhibit personal responsibility and do hard things even at home. It's time to tell the kids no more sleepovers. It's time to stay home and really mean it. Keep yourself safe. If you're in industry and you have the ability to make PPE, make hand sanitizer. If there's any distiller on this call, you can make hand sanitizer just as easy as you make vodka. And that's what they're doing now in North Texas. If you make garments, you can make PPEs. And we will be out here in Dallas County, according to the Dallas County Medical Society, by April 20th. So you can make PPEs. You can make ventilators. I'll give you a feel for that. In North Texas, we have a 672 excess ventilator capacity. Okay, now that's not Dallas. That's North Texas. That's for 7.6 million people. 672 excess capacity ventilators. At 3% prevalence rate, you are well beyond the capacity of those ventilators. Here's what that means, folks. What that means is we'll have to move to the North Texas, and every one of you have this. We'll have to move to the North Texas Mass Critical Care Plan. What does that mean? That means each patient, whether they had a heart attack, they have COVID, they were in a car wreck, will be scored, and it will be determined what care they get. Some will be told who would normally go to a hospital, you need to stay home. We will provide palliative care. Some will be told you can come to the hospital, but you won't, when they get there, they'll find that they're not one of the ones that gets the ventilator based on how bad that is at that time. That's why when we talk about flattening the curve, the high curve means everybody's sick at once, okay? That means a lot more people die. if the same number of people get sick over a longer period of time, there's a baseline underneath that of medical assets, and our assets will, be able to save more lives. Last thing I want to say to you is a lot of our first responders are going to go down. Okay, they're going to get sick because they're out touching these people. And even more than that, our healthcare professionals are going to go down. And so I'd ask you to remember that too. Isn't it fair that the people who are going to put their lives on the line to save your life have the best chance to save their life? And that's what Shelter in Place does. And with that, I just want to say I love the Lyceum, love all y'all. Sorry I was late to get on the call.
Hey, Judge, if you have time, we had one question specifically for you, but we can let you go. I know we're
Sure.
past.
No, if it's fast, go ahead.
This question was around loan companies, and they said, I understand the need to have payday loan companies closed, but shouldn't other non-depository financial institutions like auto finance mortgage servicing companies be open during these critical times?
No one is closed. We're just asking people to work from home. The thought behind that, so, hopefully you can still service your clients from home. By the way, you can go to, since we're pretty much everybody's following what we do here in Dallas County on their own orders. So you can go to business, the word, and I know I have a drawl, so that's spelled the way it is in the dictionary, not with the B. Okay. So business, COVID-19 at dallascounty.org. And you can lay out your, my industry does and such. And the team of lawyers that are looking at that will look at it. Here's the idea of the depository. It's not to pick on payday lenders, although I can't stand payday lenders. I'll be honest with you. I think, they're pawn scum. And if there's any payday lenders here, hey, nothing personal. I just think your industry is a bunch of pawn scum. The thought is a depository lender like a credit union, people will go into to the bank to do business, and a mortgage lender that is not in a bank, most of that stuff can be done online. So you still service your clients, but you just do them on the phone. And remember this is to protect you as well as these other people. We want to keep you and your family safe.
Yeah, thank you. Thank you all again for taking the time to join us. And Judge, we had several folks reach out and shared their support for your leadership and your, taking the first move. So we wanted to pass that along to you as well. Everybody take care. And this recording will be available. We'll share it in our follow-up.